Welcome to this video, basic dysrhythmias, ventricular dysrhythmias. We're going to go ahead and get started looking at some ventricular dysrhythmias. Remember, ventricular meaning we're looking at the QRS complex. So again, reviewing electrical conductivity of the heart. Our electrical conduction should start at the pacemaker of the heart, the SA node, and travel to the AV node. That stimulation from SA node to AV node is known as atrial depolarization. That's contraction of the atrium. From there, the impulse goes from the AV node down the bundle of His to the bundle branches, all the way down to the Purkinje fibers. And that is where the ventricles are contracting, creating that QRS, and that is ventricular depolarization. Followed by the T wave, which is ventricular repolarization, or the relaxing of the ventricles. So in our complex there, we can see we have a P wave, a QRS complex, and then a T wave, representing our one cycle of electrical activity. So the classification of dysrhythmias for this video, we're looking at ventricular dysrhythmias. They're classified by, one, the site of origin, so where they're located down in the ventricles, and two, how it affects the heart's rate and rhythm. These can be benign or life-threatening. Those that are life-threatening are usually due to decreased cardiac output or tissue perfusion. So let's go back and review our gold standard, the sinus rhythm. We look at our 5 criteria. A sinus rhythm has a regular rhythm. So if we look and measure from R to R, then our complexes will be equal distance apart. The rate is 60 to 100 beats per minute. There's one upright rounded P wave for every QRS. The PR interval, measuring from the beginning of the P to the beginning of the Q, is a normal range of 0.12 to 0.20. And then the QRS complex, measuring beginning of the Q to where S comes back up to the J point, is usually narrow, less than 0.12. With our first dysrhythmia, premature ventricular contractions, sounds very similar to one we looked at in a previous video of premature atrial contractions. So we said that premature means it comes early. So now we're looking at a premature complex that is going to be initiated by the ventricles. So we're used to electrical stimulation coming from the atrium down to the ventricles. But in these complexes, we're looking at some irritable spots or bullies that are irritable in the ventricular area. So in addition to information that is coming from the SA node down to the Purkinje fibers, we also have these irritable ectopic spots in the ventricles that are firing in addition to or in place of the SA node. So premature ventricular contractions. In our examples we're going to be looking at preventricular contractions, or PVCs, with an underlying rhythm that is a sinus rhythm. So a sinus rhythm, a sinus bradycardia, or sinus tachycardia. In the outside world, we can truly have a PVC with any kind of underlying rhythm, but we're going to be looking at identifying them in a basic strip. So if we think about something being elicited or started in the ventricles, we know that corresponds to the QRS complex, right? So our premature ventricular contraction won't have a P wave, because a P wave would mean it was coming from the atrium. So in our strip there where the arrow's pointed, we can see that complex looks very weird compared to all the ones around it. The other ones around it, we can tell that they're a regular rate and a rhythm that is 60 to 100. And if we measured out those PR intervals and there's QRSs, we could see that those would be within our norm. But that one complex there, if we measured out the R to R, that complex comes early, so it is premature, but a ventricular complex is going to concentrate only on the QRS because that is where the ventricles are acting. So this premature ventricular contraction has no P waves, and the QRS complex is wide. We said a narrow QRS was less than 0.12. A wide QRS is greater than 0.12. So if we see this complex right where it leaves the isometric line all the way to where it comes back to the isometric line, that is our QR interval. So this one stands alone. It is with an underlying rhythm. So remember, we have to say the PVC and the underlying rhythm. We can say this is a sinus rhythm with one PVC, a preventricular contraction. PVCs can occur in someone who's usually otherwise healthy, so they don't necessarily say that a person needs medical treatment. Again, if we're looking at a rhythm strip, we can see that something abnormal is going on. We have to assess our patient. So treatment truly is going to aim at determining what is the underlying cause of this, and is that causing these PVCs to occur more frequently or reoccurring regularly. So you or I, again, if we've had too much caffeine or stimulants or something like that, we may have a PVC occasionally or here or there. It may feel like a little fluttering in our chest for a moment. That is not something to be concerned about. But if we're watching a patient's telemetry strip and they have a PVC, and then they have another one a few minutes later, or within one strip like these, they start to occur multiple times, this can be concerning because it is showing that the ventricle is becoming irritable in one spot or multiple spots, and it is something that we should alert the physician about. So let's look at kind of two different PVCs. In the top strip, we see that there are 1, 2, 3 PVCs with our underlying rhythm. You know, you can tell they look kind of weird, but all of those PVCs look the same. That is called unifocal PVCs because that is all coming from one other irritable area in the ventricle. If they look the same, they're coming from that same bully. But look at the bottom. We have 1, 2, 3 PVCs with that rhythm, and they look different. We have 2 that look the same. They're going upright, and we have 1 in the middle that's going down. This indicates that we have more than one irritable spot. So it looks like we have 2 different irritable spots in the ventricles that are signaling and sending electrical activity in addition to that SA node. Having multiple PVCs or multifocal spots is more concerning than the unifocal because we have more irritability. The next ventricular strip is called ventricular tachycardia. Now, the strip that we show here is solid run of ventricular tachycardia. Patients sometimes can have a short run of ventricular tachycardia, so 2 beats, 3 beats, things like that. If a strip has more than 3 PVCs, preventricular contractions in a row, that person has had what we call a run of VTAC. And that is saying that the ventricles are very irritable, and so they are firing, excuse me, they are firing and taking over for that atrium. This is very concerning. So when we think of ventricular tachycardia, the rate is going to be regular. If we measure between these complexes, they're equal distance apart. Tachycardia, meaning greater than 100. So the rate is going to be greater than 100. There are no P waves associated with VTAC because the ventricles have taken over all of the electrical activity. So there would be no activity going on in the atrium, hence no P waves. All QRSs. We couldn't measure a PR interval if there's no P waves, and the QRSs are going to be wide. They're greater than 0.12. Remember, more than 3 of those complexes in a row, it signals ventricular tachycardia. So episodes of VTAC may be brief and only last a couple of seconds. Again, a patient may feel fluttering or may feel short of breath, but they will pass and go back into another rhythm. But episodes that last more than a few seconds, so more than those 3 beats, are called a sustained VTAC, and this is life-threatening. This can cause a sudden cardiac arrest. With VTAC, we need to check our patient, check the status of our patient, and check for a pulse. Patients can be in VTAC and still have a pulse. Now let's think about this. VTAC is the ventricles that are firing alone. So if the ventricles are firing alone, we still have a heartbeat, right? It's ventricles that are firing and firing and firing. If this advances to a pulseless VTAC, that means that the ventricles are sending electrical impulses, but it's not going along with contracting anymore. So does a patient have a pulse or not a pulse? We're treating the patient. So think about if we approach a patient in the patient's room or even on the street and we check for responsiveness, we are going to check a pulse. What do we do if there's no pulse? We're going to start CPR. So think about VTAC. We're going to assess the patient. We're going to check for a pulse. No pulse, we start CPR. What are the reasons for VTAC, particularly a sustained VTAC that is now turned into a cardiopulmonary arrest? There's no pulse. So they call the reasons of this the 5 H's and 5 T's. And so this either has to do with problems with oxygenation, problems with fluid volume that carry oxygen, electrolyte disturbances, or problems with cardiac problems with the heart. So the 5 H's, hypovolemia, again, low blood volume. It carries oxygen, right? Hypoxia, so low amount of oxygen. So if the patient has a respiratory problem or they've had a heart attack or anything like that. Hydrogen ion. So think about acidosis and alkalosis. Hypo or hyperkalemia. Remember we talked about potassium. Too low or too high can cause cardiac problems, dysrhythmias. Our biggest concern is the patient would go into VTAC, which is life-threatening. Potassium is extremely important when we're monitoring our lab values. Hypothermia, so low body temperature. That can affect the heart muscle, the pumping of blood. The 5 T's, toxins. Anything that gets into the bloodstream that's a toxin can affect the heart muscle. Tamponade. Tamponade has to do with the pressure that's exerted on the heart that can cause the heart to go into this lethal rhythm and not be able to transmit electrical activity. Attention pneumothorax. Again, a pneumothorax is when one of the lungs has been compressed and it's no longer able to inflate and bring oxygen into the body. So again, thinking about oxygenation status. A thrombosis, so a blood clot, either a pulmonary embolism or a blood clot in the coronary artery, and then any kind of trauma. So the patient's been in an accident, they've lost lots of blood. That can cause the patient's heart and the heart muscle to go without oxygen and cause them to go into this lethal rhythm, this problem with electrical activity. The next rhythm is called ventricular fibrillation. So again, we're moving from V-tach to V-fib. V-tach, we said we had irritable areas in the ventricles that were causing the ventricles to contract very quickly. If we progress into V-fib, remember what we said fibrillation is. It's quivering. It's no longer squeezing or contracting. It's just fibrillating or quivering. So this is worse for our patient. Fibrillations are always irregular, a chaotic rhythm. We can look at this and say there's no regular pattern that goes with this. The rate is not present, so there's really no QRSs, no QRS complexes that are there. We can't really tell what's going on. We can tell that there's some irregularity and some quivering going on. Now, we talked about atrial fibrillation, so I may ask you, how can you tell this is not atrial fibrillation and that it's ventricular? Well, remember, if we were talking about atrial fibrillation, we would have quivering of the atrium, quivering of the P waves, but we would have a normal QRS. In this complex, we don't have any normal QRSs. So all we're seeing is the quivering of the ventricles, ventricular fibrillation. P waves are absent. Again, those waves or that quivering we can say is either fine or coarse. Coarse V-fib is going to be at the beginning of that bottom strip that we can still see some of those distinct waves moving of it fibrillating or quivering. When it's worn out, it's going to go to fine V-fib. So the quivering has gotten quieter and quieter, and all it is doing is fibrillating or quivering a little bitty bit. The V-fib is not compatible with life. We are not going to have cardiac output with V-fib. We can't measure a PR interval. Our QRSs are absent. So all we know is this is what we're left with, V-fib, ventricular fibrillation. There's no depolarization, no contraction, no effective cardiac output. If you'd like to see a picture of a heart that is just quivering with V-fib, click on this link and you can see a pig's heart with V-fib. V-fib and pulseless V-tach. These two rhythms are shockable rhythms. So again, if we are assessing a patient, either in their room or out in public, we come upon a patient, they're unresponsive, Mr. Jones, we tap on our patient, call 911. We're in the hospital, we push a code button, say, get the defibrillator, get an AED. We check pulses. We are not going to feel a pulse with pulseless V-tach or V-fib. We're going to initiate CPR. When the defibrillator or the AED gets back, we are going to hook it up to them and we are going to continue compressions. When the monitor is assessing their heart rhythm, it will say stop compressions, assessing with the AED, and it will tell us if it's a shockable rhythm. If you are the primary nurse, you stay with that patient, you have to be the one to give information to the code team about what could be causing this. They don't know this patient when they show up. You do. So you're going to have to tell them what medications the patient was taking, what they were there for, if there was any symptoms before this happened. You are the information giver. This doesn't mean you know exactly why they're in V-fib, but you have to be able to provide information about the history of this patient. So again, make sure that we are treating this patient as unresponsive and we are following this system, not trying to treat the EKG strip. Let's look at the CPR guidelines for 2020. These are still current for the 2022, and they are from the American Heart Association, so you can click on that link to review. Early defibrillation, minimizing chest compression interruptions is most important. So we want to make sure that we are continuing compressions and giving our oxygen. The only time we're going to step back and stop is when the AED is assessing the heart rhythm, or we are putting the pads on for the defibrillator to assess. So patients unresponsive are going to call for help. We're going to call for the AED, check pulses, do chest compressions, and give our oxygen the way that we should. We're going to defibrillate as indicated. So remember, we should change chest compressors about every 2 minutes or sooner if you get fatigued. If you're doing CPR compressions correctly, about every couple of rounds, you need to change because you're going to be tired. We want to make sure we're doing those good deep compressions. Push hard and push fast. So with the CPR guidelines, it's a 30-to-2 ratio, 30 compressions, 2 breaths. We want to keep a heart rate of 100 to 120. Think about the song Baby Shark. So it's a fast, steady rhythm. That is what we should be thinking and singing in our head when we're doing compressions. The depth of those compressions, 2 to 2.4 inches. We have to make sure that we are completely, after we compress, going to the top, not pressing down or putting our weight on the body so that the chest can completely recoil before we do that next compression. When we are attaching a defibrillator, again, looking at the patches, there will be instructions on the patches, 2 different ways to put on these. If possible, we can put them on both on the front of our patient, or we put one on the front and one on the back. Again, if you look at the pads, it tells you exactly where they go. We want to make sure there's a good stick to the patient's chest. So if you have a really hairy patient, yell for someone to bring a razor and you might have to shave a small area to stick that patch on. The last ventricular rhythm is called a ventricular standstill or asystole, or sometimes it's known as a flat line. We're not going to have any rhythm or rate of rhythm. Many times it's a flat line, but you may see some random P waves. So remember, a P wave is a blip of information that's trying to come from the atrium. But without a QRS, it is not making contact with the ventricles. So we have no ventricular contraction. There's not going to be any PR interval. There's not going to be any QRS. So we either have a straight line or we may have some random P waves. You do not shock ventricular standstill or asystole. It is like shocking trying to start a car with a dead battery. So we're going to continue CPR, and we are trying to find out what could be causing this. They are going to administer medications to help try to restart the heart, but with asystole, it is not defibrillation. So a cardiac arrest, asystole, again, a flat line, we will have no pulse, we will have a flat line or random P waves. Start CPR, look for the cause, try to determine the cause, again, and continue those chest compressions. So here are a couple of last strips that we can look at and we can say, what could be going on here? What do you think? Let's look at A. So A looks like there are some normal complexes here. So let me grab my pen. It looks like we may have a couple of normal complexes. And I say that in that I think that if we looked that they are an equal distance apart, that it looks like if we were to count the rate and we were to count these other complexes as well, that we may be 60 to 100. 1, 2, 3, 4, 5, 6, so 60. These are our complexes that have a P wave. We could measure a PR interval. We could see we have a narrow QRS. So what are these things? These are actually PVCs. So again, there's no P wave, but the QRS is wide, measuring from here to here. So we have a wide QRS. So this would be sinus rhythm with 1, 2, 3 PVCs. If we have PVCs that occur every other beat, we could also call this bigeminy, but you don't have to do that. You can say sinus rhythm with 3 PVCs. So what's going on in the second one? What's going on in B? Is it regular? Well, if we measure these apart, they're an equal distance apart. What is the rate? So let's count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. That's 150 beats per minute. So it's definitely fast. There's no P waves, but we do have a wide QRS. What we're looking at is VTAC, ventricular tachycardia. How would we treat that? Well, it would depend on if our patient had a pulse, right? So we check their pulse, check our patient, try to figure out what's causing this. Our patient, if they had a pulse, is it between 60 to 100? Again, assessing our patient, we may need to supplement with oxygen, but if our patient is not having good cardiac output, then we would initiate CPR. So check our patient, do they have a pulse? If they're in VTAC here, they're definitely going to have some problems with cardiac output. This is not going to be a patient who's going to look at you and say, I feel okay. Let's go to the bottom. What's going on here? So is it regular? Nope. It looks like a whole lot of different things are going on. What's the rate? Well, if I were to count each of these, it's going to be definitely greater than 100, but I can't really tell what's going on here. Is there P waves? No. This is a whole lot of QRS, but it's not normal like it would be in a VTAC. This is the ventricles just quivering. So we have VFib here, ventricular fibrillation. And it looks like there are definitely big movements of this. So this would be a coarse VFib. So we're going to practice a whole lot more in the classroom, but go ahead and practice with some of these, counting them and measuring them yourself.